start. Today is another installment of the GlomCon ERA EDTA Roundtable discussion. Today's topic is sodium bicarbonate and cardiovascular events in hypertensive adults, results from the sprint. Our speaker is Dr. Mirela Dobre, Assistant Professor of Medicine, Case Western Reserve University School of Medicine. We are accompanied by our panelists, including Professor Denis Fouque, Editor-in-Chief, NDT, Chief of Department of Nephrology and Professor of Nephrology, University of Lyon, Dr. Swapnil Hiremath, Associate Professor and Faculty of Medicine, University of Ottawa, Canada, and Dr. Kate Stevenson, Consultant Nephrology, Glasgow Renal Transplant Unit, and YNP Board Member and ERA EDTA Counselor. And the session will be moderated by Dr. Keith Gillis, Consultant Nephrologist, Glasgow Renal and Transplant Unit, and Secretary of the ERA EDTA Electronic Communications Committee.
I would like to thank GlomCon for inviting me to present our work titled Serum Bicarbonate and Cardiovascular Event in Hypertensive Adults, Results from the Systolic Blood Pressure Intervention Trial. Next slide is presenting the writing group members, which include Dr. Pajewski, Bedu, Konkol, Hostetter, Lee, Raman, Servilla, Wiener, Wright, and Raphael. So this was a collaborative work. I'm just the one speaking here today. So this all started with the idea that cardiovascular disease is extremely prevalent. It affects a large proportion of US population and actually worldwide. And the burden of cardiovascular disease is particularly high in individuals with chronic kidney disease. In addition to traditional Framingham cardiovascular risk factors, we are all well aware at this time that non-traditional cardiovascular risk factors play an important role. And next slide presents a slide that is probably something that most of us have seen often. And even though it's relatively old, 16 years old, it remains relevant because in spite of the advancement that happened in the past 1-2 decades, we are still struggling to understand the cardiovascular pathology that affects our patients with kidney disease. This slide presents the annual mortality in general population and compare it with people on dialysis and kidney transplantation. So across all age groups, patients on dialysis, which are represented by the top line, are affected significantly compared to the general population that is presented there with darker dots. Transplantation, again, is a little bit better, but still not at the level of the general population. The next slide presents the histology of the left ventricular wall from a normal heart on panel A and from a patient with chronic kidney disease on panel D. So as we can see, the normal heart has no significant interstitial fibrosis and myocytes appear healthy and uniform. In CKD, which is the panel on the right, there is patchy interstitial fibrosis represented in blue and chronic myocyte injury throughout the wall, sparing the subendocardial zone. The next slide lists the cardiovascular risk factor in CKD. On the left, we have the list of traditional risk factors that we are all very familiar with. Age, male sex, hypertension, high LDL cholesterol, diabetes, smoking, physical inactivity, personal family history of cardiovascular disease, LDH. In addition to that, the non-traditional risk factors are listed on the right. Albuminuria, homocysteine, lipoprotein and lipoprotein isoform, anemia, abnormalities of calcium and phosphorus metabolism, volume overload, and so on. The question is, and Dr. Stevens should do a next click, sorry about that. The question is, does the chronic metabolic acidosis of chronic kidney disease contribute to the increased cardiovascular risk that we are observing in our patient population? Which leads us to the next slide, where we discuss the background and the study rationale. There are several studies in both CKD and non-CKD cohorts that have identified an association between metabolic acidosis and mortality. But is it unclear what the pathological link is? We saw that a plausible rationale for this association is the detrimental effect of metabolic acidosis on cardiovascular structure and function, and that subsequently will lead to increased cardiovascular disease and mortality. There are a few studies on this topic in various patient populations, and the results are slightly conflicting. So, what are the adverse effects of chronic metabolic acidosis? There are the effects that are well known. For example, development or exacerbation of metabolic bone disease, growth retardation in children, increased degradation of muscle with muscle wasting, reduction of albumin synthesis, impaired glucose tolerance, abnormal thyroid function, increased beta-2 microglobulin, stimulation of inflammation, progression of chronic kidney disease, and worsening cardiovascular disease is also listed here, along with increased mortality. So, what are some of the causes of, or what are some of the mechanisms that can explain the association between metabolic acidosis and adverse cardiovascular outcomes? In terms of the studies that have evaluated this idea, we could not find a wealth of knowledge coming from human models, but there were some relatively old studies done in animal models, and they all point to one idea, that acidemia causes depression of left ventricular function. And here we have the effect of infusion of lactic acid on left ventricular function in a dog model with a normal innervation. So the left ventricular function is depressed. So what can be responsible for, or what would be some of the causes? And I'm going to go over in the next couple of slides of a few potential mechanisms. One idea is that hydrogen ions will be competing against the calcium ions for binding to the myocardial protein troponin. So in order for the cross bridges between the actin and myosin to be formed, ATP needs to be broken down, and contraction to occur, the inhibitory action of troponin of actin-myosin interaction must be overcome. If we have elevated concentration of intracellular hydrogen ions, then a smaller percentage of available calcium is able to react with troponin, and fewer actin-myosin interaction occurs, and therefore the strength of the contraction is reduced. The subsequent slide lists essentially a similar idea, but here we're talking about the impaired binding and release of calcium from the sarcoplasmic reticulum in the cardiac cell. So the previous one was an animal model. This is a model done on cells, cardiac cells. Now, if such results can be extrapolated to the intact animal, then acidosis may cause a reduction in the amount of calcium that is released during each beat, and subsequently leading to the diminished force of contraction. Another potential mechanism, another theories are listed on the next slide, And that has to do with the fact that acidosis causes a rise in extracellular potassium, and hyperkalemia may influence the contractility as well as the rhythm of the heart. And one last idea having to do with potential mechanisms of this observed association is that humoral regulatory mechanisms that help increase urinary acidification needed in patients with CKD, such as RAS activation with elevation of aldosterone and stimulation of endothelin, these hormones can actually cause direct cardiac damage. Which leads us to the study aim. We aim to determine the association between serum bicarbonate concentration and cardiovascular events in a large cohort of hypertensive adults with and without CKD that were enrolled in the systolic blood pressure intervention trial. In addition, a secondary aim was to assess if the intensive blood pressure control was more beneficial in individuals with a low serum bicarbonate compared to those with normal bicarbonate at study baseline. This is a slide that has been presented often in the past year, so, and I'm sure everybody in the audience is well aware about the SPRINT study design. It was a randomized controlled trial that aimed to study the effect of intensive systolic blood pressure control less than 120 versus the standard treatment to a goal of systolic blood pressure less than 140 on cardiovascular outcomes and mortality. As far as eligibility criteria, at baseline, patients were supposed to have a systolic blood pressure between 130 and 180, had at least one of 4 cardiovascular risk factors, such as clinical or subclinical cardiovascular disease, an EGFR between 20 to 60, or a Framingham 10-year risk score of 15%, or an age of 75 years or older. From SPRINT, the people with diabetes were excluded. People with a history of stroke, with a cardiovascular event or procedure in the prior 3 months prior to enrollment, people with symptomatic heart failure in the past 6 months, people with advanced heart failure with a low ejection fraction, less than 35%, also people with heavy proteinuria, more than 1 gram per day, or the equivalent based on the spot urine measurement were excluded, as well as people with polycystic kidney disease, people on immunosuppression, and people with coexisting disease likely to affect survival or an organ transplant. The next slide presents selected baseline characteristics. A total of 9,334 participants with an available serum bicarbonate concentration at study baseline were included in our study population. And this table lists their baseline characteristics by the 3 groups of serum bicarbonate: less than 22 milliequivalents per liter, which was considered the group with low serum bicarbonate; the group that was considered normal, between 22 and 26 milliequivalents per liter bicarbonate concentration; and the high bicarbonate group that is here presented with a level of serum bicarbonate concentration above 26 milliequivalents per liter. Participants with serum bicarbonate less than 22 milliequivalents per liter were more likely to be younger, to have a history of coronary vascular disease, to have, as expected, lower GFR, higher albuminuria, and they were taking ACE inhibitors or ARB. And they were less likely to take diuretics compared to individuals with a bicarbonate concentration above 26 milliequivalents per liter. And we go to next click. I just wanted to emphasize how strongly, again, as expected, how strongly the bicarbonate level is correlated with markers of kidney function, creatinine, GFR, albuminuria. In analysis, in Kaplan-Meier survival curves, looking at the three main outcomes, which were primary cardiovascular disease outcomes, in SPRINT defined as non-fatal myocardial infarction, acute coronary syndrome not resulting in an MI, a non-fatal stroke, non-fatal acute decompensated heart failure, and death from cardiovascular causes, and heart failure and all-cause mortality. So as we can see, the group with baseline serum bicarbonate concentration less than 22 milliequivalents per liter had the highest cumulative hazard of the primary cardiovascular outcome, and the difference was statistically significant compared to the other two groups. We observe a similar trend for the heart failure outcome and also for the all-cause mortality outcome, but the association did not reach statistical significance, and we can discuss further what would be some of the reasons for the lack of association, or lack of statistical significant association. The slide presents the results from Cox regression model, looking at the serum bicarbonate as a categorical variable, and the group of bicarbonate between 22 and 26 was taken as reference. So, Kate, if you would do one more click, please. Serum bicarbonate group less than 22 compared to the group of 22 to 26 had a higher risk of primary cardiovascular outcomes. The three models listed here, the first one is just adjusted for the treatment group. Model 2 is adjusting for demographics, age, sex, race, ethnicity, and in model 3, we included all the demographic variables listed in model 1. In addition, we added smoking, history of cardiovascular disease, systolic blood pressure, diuretics, ACE, or angiotensin receptor blockers used, eGFR, log urine albumin for creatinine, and a serum potassium. One other thing to mention here, we had a total of 618 primary cardiovascular events, 173 heart failure events, and 378 that were included in the analysis. So the association between low bicarbonate and primary cardiovascular outcomes was significant across all three models. We did not find a similar statistical significant association for heart failure and all-cause mortality, though in the model 1, there was a trend for, it was statistically significant for model 1, but as we apply sequential adjustments, that association become less strong. On panel on the right, the group of serum bicarbonate above 26 milliequivalents per liter, we did not find any statistical significance between serum bicarbonate and any of the events. And this is relevant because in a similar paper we published using the TriC cohort, a serum bicarbonate above 26 was statistically significant associated with heart failure events. One rationale for such difference in findings might be related to the number of events that were found here in SPRINT. As we all are aware, the SPRINT was stopped early just because of they reached their their goal, but should it be continued for longer, and should we have observed more heart failure events or all-cause mortality, it is possible that we might find further statistical significance association. In the next slide, we looked at serum bicarbonate longitudinally in nonlinear modeling, knowing that there are several cohorts that found a U-shaped association between serum bicarbonate concentration and mortality. And in our model, in the sprint cohort, the nonlinear modeling did find a similar association between low bicarbonate concentration, and that is a level below 22 milliequivalents per liter, and the risk of primary cardiovascular outcomes. The other two outcomes, heart failure and all-cause mortality, did not reach statistical significance. The next slide is trying to answer the question whether the effect of intensive blood pressure treatment on the primary cardiovascular outcome, heart failure, and all-cause mortality was different by subgroup of serum bicarbonate. And as we can see here, irrespective of the bicarbonate group at baseline, the intensive group favored for across all three outcomes. And I was talking earlier about the N so the sample size for the heart failure and all-cause mortality. So we have 5 events for heart failure for the low bicarb group, and also 10 events for all-cause mortality, which might have prevented us to find more significant association. The next slide is going over the study strength and limitation. So this was a large cohort of hypertensive patients that was randomized to the 2 systolic blood pressure targets. They included individuals at high risk for cardiovascular events, and that allowed for a thorough analysis of the link between bicarbonate concentration and cardiovascular endpoints. So overall, the cardiovascular disease outcome, the composite cardiovascular disease outcome, confer a strong sample size to allow for such association. However, there are some limitations that come from the nature of this study. This was an observational study in nature, and therefore causality cannot be inferred. And there is always, like with any epidemiological study, a certain degree of residual confounding that cannot be excluded. Another point to make is that the full ascertainment of acid-base status with blood gas analysis was not possible. We have just the serum bicarbonate concentration level available at baseline. However, important to note that at least in patients with kidney disease, similar studies that had available venous blood gas found that a low bicarbonate in more than 60% of cases would be associated with a low pH, so with acidemia. As I mentioned, we had low power to detect significant differences for all-cause mortality, kidney events, and heart failure. And since SPRINT did not include diabetics, we could not extrapolate our findings to the diabetic patient population. And we only had a single measurement of serum bicarbonate that was included in this analysis. And with that, I thank you. Oh, one last slide. I'm sorry, I was rushing. So in conclusion, serum bicarbonate less than 22 milliequivalents per liter was found to be independently associated with the high risk of cardiovascular events in hypertensive individuals. The effect of intensive blood pressure lowering on cardiovascular outcomes was not modified by the levels of serum bicarbonate. And We definitely need future studies that should determine the underlying mechanism that links serum bicarbonate with this adverse outcome. And in particular, we should pay attention to the underlying acid-base abnormality and should assess if the treatments to correct such abnormality will eventually lead to improvement in cardiovascular outcomes. And I think that was in brief the presentation of our paper that was published in NDT. I will be glad to take any questions.
Mirela, thank you so much for that comprehensive presentation of your paper and the surrounding literature. That was absolutely fascinating. So got a diverse panel here today, and I'm excited to have Denis Fouque, who's got experience both as a scientist as an editor of NDT. So I might start off just with asking a general question for Denis. So as an editor of NDT, what excited and interested you about this research?
Can you hear me?
Yeah.
I can hear you well, yes.
Thank you very much for...
I could not understand everything that Ali said, but I can hear you well.
Okay, excellent. So thank you very much for this invitation. For an editor-in-chief, what is important is to discover new relationships. And although this trial was not designed to test the effect of acidosis, these are indirect ancillary data that in fact allow to better define the role of acidosis in kidney failure. And we all know that acidosis in dialysis patients is very harmful, has a lot of bad effects on physical activity, on albumin synthesis, for example. And it's interesting to see that acidosis is even present before dialysis and is associated with cardiovascular abnormalities way before end-stage renal disease. So these patients are approximately stage 3B, 3A and 3B. And although there are not many in this study, they already show a deleterious impact of acidosis. So for an editor, what is important is really to promote this information. And this paper has been published in August 14 online. And the altmetrics result is almost 30, which is a very good success and ranks between the best papers of NDT so far.
We are very grateful that you allow us to publish in NDT. We think it's an important work. We think that it contributes to science. I think it leads to more questions that should be studied more in depth as far as the mechanism. So more mechanistic studies in the future, either in animal models or in patients, and definitely a definite intervention trial that would be aimed at correction of metabolic acidosis and evaluate for potential improvement in the outcomes. That would be something to dream of, at least from my standpoint.
I fully agree. We already have an interesting intervention to slow progression of kidney disease, as you may know, in Jason a couple of years ago, administering bicarbonate for 2 years, approximately 2 to 3 grams per day, which effectively reduced the progression of kidney failure.
Absolutely.
And I know there was some recent data published and presented at the ASN recently with regards to bicarbonate. Swapnil, do you want to discuss any of that data that you might have come across recently?
Thanks. Firstly, of course, thanks for having me. And as I said, I have a huge bias. I love sprint. And I'm happy with the different analysis that have come out of sprint. Before I go into what was presented at ASN, if I could ask, Dr. Dobre did mention residual confounding. If you look at the table 1, almost all the covariates are different. The patients who have low bicarb are dramatically different than the patients who don't. And you always wonder if there is residual confounding. You did mention in the limitations. And in fact, the attenuation is such that makes you wonder a little bit. I do agree that I think the effect is consistent for the cardiovascular events as well as the all-cause and the heart failure. The fact that it crosses over 1 is just a small number of events. For all-cause mortality, you have like a total of 26 events in the low bicarb group and 15 in the heart failure group. But overall, this seems consistent with other findings about metabolic acidemia being bad. I do remember, I'm aging myself a little bit here, but I'm sure Professor Rodby, who is on the, who's listening in, would agree that when we trained, there was the concept of an acid ash diet. I don't know if anyone here remembers that, that acid ash diet is bad for kidneys and is bad in general. That kind of paradigm went away. But you can Google acid ash diet and you'll see some really old papers talking about that, and maybe it's making a comeback. The question I have, of course, is apart from all this, is this something that is related to the diet rather than metabolic acidosis itself? There's a recent trial published in the American Journal of Nephrology by Dr. Goraya and Dr. Wesson's group from Baylor. What they tried to do was to fix metabolic acidemia with bicarbonate versus a fruit and vegetable diet. And the initial trial, it showed that both of them could fix the acidemia. They report the 5-year outcomes in this recent trial, and they show that the fruit and vegetable diet also improved things like LDL cholesterol and other calcification markers. So there may be something else that's going on, and it's not just the bicarb that plays a role. As far as the recent studies that you're talking about, yes, there seems to be a consistent trend that giving bicarb or fixing acidemia seems to lower the risk of CKD progression. Though there is still the jury is still out there. I saw on Twitter that there was a paper presented at the British Geriatric Society, I think, which was negative. It's a 300 patient trial, which was negative. So I think we have to wait for that to be published and the totality of evidence to be seen before. But I'm keen to hear what the other panelists and Dr. Dobre thinks about the diet effect versus the metabolic acidosis effect.
I thank you very much for this question. These are all very good points. I'm well aware about Dr. Wesson's group publication on fruits and vegetables, and this is important to note here. So we have people with really very mild kidney disease. Their creatinine at baseline in group of low bicarb was just 1.3. So at this degree of GFR, you won't expect, which was the GFR was about, the mean was 59. You won't expect to have significant metabolic acidosis that would be specifically due to impairment in kidney function, which makes you think, is it coming from diet? Is a westernized diet the cause of what we see in terms of low bicarbonate in this group? And as such, would improvement in the way we eat lead to better outcomes altogether, renal outcomes, cardiovascular outcomes, and improved mortality? I am a firm believer in the diet rich in fruits and vegetables to combat the many diseases of our century, including kidney disease and cardiovascular disease. So I do not specifically have a preference to give bicarbonate versus fruits and vegetables. The only thing that I am struggling, at least in my clinic, is to have patients being able to afford a diet rich in fruits and vegetables, when it's much easier to go around the corner at McDonald's and buy a hamburger rather than going to the fresh market, which we all know it's a little bit more expensive, at least for the population that I'm serving here in Cleveland. So overall, I think we can achieve, and I do believe the studies published by Nimrit Goraya and Don Weston in Texas, I think we can reach the same goal with medicine with sodium bicarbonate versus fruits and vegetables. And if we correct metabolic acidosis, we might be able to see improved outcomes.
So I think that that's the key, Mirela, isn't it? The idea of seeing this translate to improved outcomes. So I always think this is quite reminiscent of the phosphate story, in that there's lots of work demonstrating that phosphate is bad, and there's sort of been various attempts to look at why that should be, so looking at a mechanism of action. And I think so down the line, years of research later, we're still at the same point, aren't we, where we know that phosphate is bad, but we haven't actually identified whether or not lowering phosphate improves cardiovascular outcomes. There was the study from the Italian group, which was presented at the ERA last year amidst probably a bit of controversy because the results were so good, where they demonstrated that giving bicarbonate significantly improved every outcome. And I think that that's one of the big issues with all of this, is that we don't have a clear answer. So I think a randomized control trial would be good. So that was the first point I wanted to make. And the second thing I wanted to say was, and this is maybe a wee bit unfair, but I wondered, had you, so obviously a bicarb of less than 22 might not be that low. Had you managed to tease out whether people who had a particularly low bicarbonate, so for example, down at 16, 17, and that maybe wasn't possible because perhaps your patients didn't have advanced enough CKD, but I just wondered if you'd looked at that at all.
Yes, unfortunately, we did not have enough number of patients with really low bicarbonate to conduct a meaningful analysis. Definitely, we will probably need to enroll patients with more advanced kidney disease to be able to allow such analysis. I am aware about a group, I believe it's from UK, that had conducted this pragmatic trial in elderly population. Yeah. And they aim to specifically people with more advanced kidney disease and with more severe metabolic acidosis with much lower bicarbonate levels at baseline. But in SPRINT, unfortunately, the number of people with bicarb less than 20, even less than 18, definitely was minimal. So that analysis won't be able to be conducted using this current cohort.
Yeah, and I suppose the sort of big, I alluded to phosphate, but I suppose the big advantage we have here is that we don't have a drug company monopoly. So we might get a randomized controlled trial. We might well be able to demonstrate that improving acidosis does have a significant benefit.
Can I ask the important role of acidosis starts below 23, in fact, millimole per liter, and there is an abundant literature on metabolic impairment, notably by Dr. Mitch from Texas, and he clearly showed that just below 23, there is a lot of abnormality. So acidosis is not 16 or 17, it's just as important below 33, 23.
23, yeah, not 33.
Mirela, I was really interested in the U-shaped association between bicarbonate and survival, which again is as much as we see in parameters like phosphate as well. Do you want to maybe talk a wee bit about what you might think underlie that association, that U-shaped curve that we see?
With mortality.
Mm-hmm.
So there is slightly more data on the lower end of bicarbonate, so a little bit more data on metabolic acidosis that would lead to mortality, right? You will stimulate inflammation, you will stimulate renin-angiotensin system with metabolic acidosis, leading to inflammation, leading to subsequent fibrosis, and maybe adverse cardiac events, heart failure, and so on. As far as the upper end of bicarbonate, so metabolic alkalosis, I think the jury is still out there. I can tell you some of the thoughts we had when we did the analysis in TriC cohort. because there is where we found a significant association between bicarb above 26 and heart failure events. And that was consistent when we looked at one measurement of serum bicarbonate at baseline. And when we did multiple measurements and we consider all serum bicarbonate measurements through the years in TriC, and as we know, there are many years, 11 or so we had, and that persistent serum bicarbonate paper we published. So several possibilities there. But the only thing that is relatively better study is related to metabolic alkalosis leading to calcium and phosphorus deposition, so worsening vascular calcification, and that could potentially lead to mortality. But this is a lot of hand waving here because there are not clearly mechanistic studies. They're just hypotheses. And the only thing that has been proven so far is that alkalosis will lead to worsening calcification, vascular calcification, and subsequent mortality with that. We'll welcome any other potential thoughts on this topic, but that's the thing that has been so far present in the study that I reviewed to date.
Sure, because I think it's interesting in some of the earlier interventional studies that have been published have even aimed for quite a high bicarbonate above the point in which we see an increased mortality. So I think it's interesting to see some of these discrepancies in some of the data. Denis, have you got any comments upon interventional studies that you might like to see in the future about correction of acidosis? I know that there's been some novel bicarbonate binders, for example. Have you had any thoughts about the kind of trials that you'd like to see to improve patient outcomes in this field?
Yeah, these interventions are quite easy to do. It's easy to take bicarbonate, sodium bicarbonate orally. We do that in all our patients. We did some clinical trials giving 2 grams per day, which routinely corrects acidosis quite well in CKD patients. And the other side is that changing food pattern may be interesting because, as you know, if you eat animal proteins, you get into acidosis. If you eat vegetal proteins, you get into alkalosis. And when people goes from a Western diet to a vegetarian diet, you easily see how the bicarbonate rises. And it's another way, as mentioned by Dr. Wesson already, as by Dr. Wesson, it's easy to get a good correction, as good as bicarbonate pills, for example. So moving to a fruit and vegetable diet allows a good correction of acidosis. So I think we have a good intervention possibility, and then we have to define which population we want to study this. And in the present study, it was interesting to see very mild CKD patients. Usually, those studies are done in more severe CKD patients, but here it's almost a normal population. So I think it's another field to study. And we can also go to cardiotoxic effect. And we were wondering if FGF23 was measured in the SPRINT study. I don't recall exactly, but you can see if acidosis could change FGF23, for example.
FGF23 was not measured in main SPRINT study. It was measured, however, in TriC, and we had a sub-cohort of TriC population that was that had available FGF23 levels. I believe it was at year 1 and then several subsequent years after. But when we looked at the preliminary association between bicarb and FGF23, we did not find significant association. that might be due again to the sample size at that time. But in sprint it was not available.
Okay, so next studies possibly to do.
So I was just having a wee look, Denis, just online while you were talking. So there was a study looking at endothelial function and the effect of acidosis correction on that in CJSON about 18 months ago. So they measured FGF23 in it was a small crossover study, so there was only 18 patients. But they found that actually in the treatment arm, FGF23 level increased when they corrected acidosis. Could you hear me okay?
Better.
Yeah. Did you hear? Did you hear what I said? No.
Just last part of your sentence.
Oh, sorry. So I was having a wee look at the effect of acidosis and endothelial function and seeing what studies were available. And so there was a small pilot crossover study published in CJSON about 18 months ago. So they measured FGF23 and they found that when they corrected acidosis, FGF23 level went up. So it increased, and they also found that phosphate increased. I don't know how they measured the FGF23, like what assay they used, but.
I'm conscious that we've spoken quite a lot about diet, and I think patients are given quite a lot of complex advice about dietary interventions, lowering phosphate, lowering potassium intake, and now we might talk about trying to reduce acid intake or acid generation as well. Swapnil, do you want to maybe talk a wee bit about these kind of contradictions that we ask patients to adhere to and the difficulties of dietary interventions that patients might face in your experience?
Yeah, so I am pretty nihilistic about many of these interventions. I guess you chose the right panelist to ask this question. Change in behavior is very difficult, right? We know that patients spend 15 minutes with us and we spend 2 minutes talking about the diet. How much of that is going to sink in? In my field where I do more hypertension work, even restriction of salt is so difficult. So sodium is present in everything. So a change in diet requires a change in lifestyle. I'm not saying it doesn't work, but it only works in the motivated patient. Someone who's really motivated is going to find out they're going to change how they eat. Otherwise, just telling people don't eat this or eat a little bit more of that is less likely to be useful. And again, this is my opinion. A pragmatic intervention trial might be more useful to find out if it really works. Otherwise, it's not that these things may not work. It's just that in real life, they may not work as much as they would work in a carefully designed RCT. On the bicarb aspect, I wonder if any of the other panelists or the people listening in would comment. We don't use bicarb tablets locally, so we do pay attention to bicarb, but we don't use bicarb tablets. We say use baking soda, and 1 teaspoon is about 64. So we say half a teaspoon of baking soda, which is about 32 millimoles of sodium bicarbonate, which is about 4 of those big tablets that you might have to eat otherwise. Again, people can go wrong. So the nurses spend a lot of time educating. So, sprinkle the baking soda over your cereal or something. I don't know if what you guys use, does everyone use sodium bicarbonate tablets?
Yes, we have sodium bicarbonate tablets available. We also give the patients the option of using baking soda. The only problem with that is that it's the palatability of it. Many do not have a taste for dissolved baking soda. So many of them said it's better with sodium bicarbonate tablets. But I agree with you. It works just the same. In terms of dietary intervention studies, I agree with you. They are tough to do. I think the only way it worked in Texas with Dr. Weston is when he did it in a controlled environment, and I think he did a joint collaboration with the food bank, where he will provide food and vegetables, lots of it that will cover not only the patient but family members too. So that you needed to make sure they took enough of the portion of fruits and vegetables daily that was needed in the study. So it is possible, but it's not easy to do. And I agree with you; it requires a lot of motivation from the patient standpoint to do it. And again, here in the area where I practice, it all comes down to affordability of such diet. But definitely a pragmatic trial, maybe involving the food banks, would be something to look forward in the future.
We've got a comment from Ali saying that he loves the taste of baking soda. So I think we need some recipe suggestions from Ali there. And we also had a question from Swati Arora just regarding Viverimer for metabolic acidosis, which I think was published in the Lancet within the last couple of years. Just wondering if any of the panelists had any comment upon this novel bicarbonate supplement or acid binder.
So I participated in a couple of TriC meetings, and the disclosure was on the first slide. But I do not have any investment in the company, so I guess I can speak about it a little bit. I think the mechanism of action is pretty cool. It acts like a binder. In fact, the engineers, like the chemists who developed Patiromer, are the same group who are now developing the Viverimer and trying to sell Viverimer on the market. So it's yet another mean of treating metabolic acidosis in CKD. There are no trials to compare head-to-head against sodium bicarbonate. The pitch about the Viverimer is that it doesn't have the sodium component. So in a small proportion of patients that were in intervention trials of sodium bicarbonate, that received sodium bicarbonate, there was some risk of worsening edema or some risk of admission for heart failure. But overall, this risk was not significant, at least in the trial that we did here in Cleveland with Dr. Hostetter. Compared to placebo, sodium bicarbonate did not, in fact, lead to more admissions for heart failure or worsening edema. So Viverimer will not have that side effect that the sodium bicarbonate has. And a head-to-head trial will definitely be something that would be needed in the future. It's just another mean of treating metabolic acidosis that will soon be available to us.
Denis has said to the group that the problem is not the diet change or not changing the diet, but the amount of time that we allocate to it, as Swap has already said. So I think that's probably very true. So I think that actually there's an awful lot that we could do if we got people to modify their diet. And one of the big problems we have in the UK is that everything is very individualized. So the diabetes doctors deal with diabetes, the renal physicians deal with the kidneys, and a lot of these patients have overlapping conditions where they're getting dietary advice from lots and lots of different places. And I suspect if we took the time and we invested some money in dietitians to educate holistically, we might actually find that we could get the patients to adhere and we could get significant improvements. And maybe we wouldn't have to get them to sprinkle their baking powder on their food.
Yeah.
So that's been a great discussion. Has any of the other panelists got any questions that they want to pitch to Mirela regarding her paper? Mirela, you just mentioned during your presentation that you had some thoughts about the lack of association between bicarbonate and heart failure, and that's similar to some of the earlier work that you've done in the area as well. I know using imaging measures of left ventricular hypertrophy. Is there anything that you want to talk about that lack of association between bicarbonate and heart failure, which is in contradiction to the association between bicarbonate and more atherosclerotic events?
So in Sprint, in this publication, we did not find a significant association between low bicarb and heart failure events. We did see a trend towards worsening heart failure in the low bicarbonate group, but when we adjusted for kidney function and history of cardiovascular disease and some other risk factors, the association became non-statistically significant. When we compare with the findings in TriC, this was a little bit different, and I think it has to do with the type of cohort that we are discussing here. Obviously, SPRINT had a much healthier CKD cohort, and it also involved a significant part of people without kidney disease, as opposed to TriC, where we have advanced kidney disease. In TriC, I don't have it here separated by atherosclerotic event versus heart failure event, or at least it's not part of the results that were published. But we did look at atherosclerotic events versus heart failure events, and for atherosclerotic events in SPRINT, we did not find an association, and this was quite consistent with the results in TriC, where we also did not see an association between bicarbonate and atherosclerotic events. And this is a little bit counterintuitive, because if we think that the mechanism is the mechanism by which metabolic acidosis will cause worsening in events will go through inflammation, so we would think worsening atherosclerosis, that acidosis leads to inflammation that leads to atherosclerosis, you would expect that you will find clinical events. Well, we didn't really see it in practice. So then we are left with a non-atherosclerotic event, with the heart failure event. So then it's a matter of volume. So one explanation for finding the significant association in TriC between heart failure events and level of serum bicarbonate at baseline was that that abnormalities in acid-base balance would lead to worsening inflammation, vascular stiffness, worsening, and therefore worsening heart failure events. This is, again, a lot of supposition, but that's the only thing that made sense. So contrary to our hypothesis that worsening acidosis will lead to worsening inflammation and worsening atherosclerotic events, we did not find that in either of the cohorts, either SPRINT or TriC.
Yeah, that's really interesting. And I might put a question just to the panelists, which would be, do you think any of you would change anything or anything specific about your practice on the basis of this data that's been presented?
So Swapnil here. So in our patients, we do, of course, assess for metabolic acidemia and fix it. But I think the point that Mirela made earlier also is these were not patients with CKD necessarily. This is actually very interesting to see that this effect is seen in the non-CKD population. This means that perhaps family physicians and other people should be paying attention to bicarb even in the non-CKD setting, if these findings are, confirmed, replicated, and so on. But those studies should be done. I think this is very promising and it should be pursued.
I think dietary counseling should be part of any practice, and it should start early. We learn a little bit in medical school, but when it is to actually preaching in the office is tough, because we get stuck with what medication we should change to control blood pressure and diabetes and so on, and we forget about the basic stuff. Advertising for a healthy diet and healthy lifestyle, and that should start early before they start developing any of the complications, including CKD, including heart failure or diabetes. I think that's the main point, and it's well spotted. The dietary intervention should be advertised early.
Yeah, more investment in dietary education and early on, absolutely.
think it's an important point because these people, of course, don't have diabetes, so you have only mild CKD. As Swapnil mentioned, they may be seeing their family practitioner, in this country their GP, and might not be seeing anyone in secondary care and might not have access to specific dietary advice about reducing progression of various diseases. So I think it's about getting the message out there. I'm not sure if anyone has any comments about how to get this type of data and message out to the family practitioners who might not be regular reviewers of journals like NDT or videos like GlomCon.
I think things filter through eventually. So certainly, and that's what happens in the UK. Eventually things filter through. But I think what we're saying is that actually we should be making a targeted effort to approach patients or approach family physicians or general practitioners who are seeing the patients early, so we can intervene early. So probably in the UK, the best way to do that would be education. So talking at their meetings, publishing this kind of research in less specialised journals, so in journals that they're more likely to have access to. But I think this kind of thing actually requires a big change in thinking. So certainly in this country, so we don't have enough time with the patients, and diet falls way down the list, and we often leave it to the dietitians who themselves are stretched and often focus on one aspect. So so clearly not in early CKD, but or people who don't have CKD, but in advanced CKD, it's often about the phosphate and potassium, and often the potassium because that's what's dangerous. So I think probably we need to have a whole rethink, and I think that this is definitely something that we should be pursuing. So we should hear more about the bicarbonate story in the future for sure.
And Denis, I'd expect that we'll hear more about the bicarbonate story in NDT as time goes on. Would you agree?
Of course, I would welcome any new submission on the topic.
Excellent. That's very good to know. Thank you very much. We'll definitely plan more studies in the field, and we'll maybe use some of the samples collected in the Hiremath trial to see if that improvement in metabolic acidosis changed any of the markers that we are interested, marker of cardiovascular disease that we are interested. So more to come, I guess.
Well, that sounds very exciting, I have to say. So it feels like our conversation's drawing to a close. I don't know if anyone has any final comments, but personally, I'd just like to thank Mirela and the panelists, Denis, Swapnil and Kate, for a great presentation firstly and a fantastic discussion of the topics thereafter. So thanks very much to all of you for this afternoon.
I thank you too for inviting me. I think this is an important topic and people should be aware. So thank you. I appreciate the opportunity.
Thank you.
Thanks so much, guys.
Thank you for having submitted to NDT. Thank you.
Anytime. Thank you so much.